Thank you. It's a uro-oncologist, and basically it simply describes a urologist whose practice is focused in genitourinary or urologic cancers. And mine in particular is focused on kidney and prostate cancer. So thanks for the invitation to speak today. I had this horrific experience last night. I decided to read the instructions to the speakers. I didn't read it earlier. I read it last night. And it said, avoid pictures of surgery, organs. It said, avoid statistics. And anyone who knows me knows that's my entire life, is statistics and organs. So I tried to edit these slides quickly. So I apologize. There's going to be some statistics, and there's going to be a few organs. Okay, but hopefully nothing too graphic for you. Okay, the first clarification. RCC is the kidney cancer that we are all here for today. That is kidney cancer that involves the meat of the kidney, not the collecting system. That would be called a TCC. So just to clear up any confusion, and I know most of you here know that, but it's a very important distinction. So when you see RCC, it's renal cell carcinoma, and that's what we often also call kidney cancer. The other type of cancer is the one that can affect your bladder and any of the lining all the way up. That's a TCC or UTUC. I will not speak to that at all this morning. Okay? So epidemiology, the numbers will vary, and they vary year over year. Kidney cancer is typically ranked at about number 8 in terms of how common it is. Having said that, those of you in the room know it's a significant cancer. All right? Obviously, prostate, breast, colorectal, lung get a lot of play. They're very, very common cancers. It does account for a number of the deaths. And in general, we're seeing more and more kidney cancer year over year. And that can be debated as to whether there's more of it occurring, or is it because of more and more access to imaging, and we're just finding these things in individuals that we didn't see earlier because we were only able to diagnose them if they were clinically unwell and came to see us. It affects men more commonly than women, and in general, people in their 60s, but we know it can be someone as young as 12, 14, and as old as 80 or 90. Risk factors. They're really not strong. I listed them here because if you read on the internet, you go into a textbook, you'll find some of these listed, but it's not like other cancers. For example, smoking is clearly associated with lung cancer and bladder cancer. With kidney cancer, there is, RR stands for relative risk. There's a slightly higher risk, but again, it's not an earth-shattering association. So I'm not advocating for smoking. If you smoke, you should stop. But the greatest benefit would be in your cardiac, cardiovascular health and risk reduction for lung and bladder cancer. All of these other ones are listed, and thank God I don't believe any of these dietary ones. Caffeine, alcohol, and protein. I love all three of them. So I hope that those are not strong predictors or risk factors. The ones that are real are in the familial bracket that you see. VHL, the von Hippel-Lindau, and some of the other hereditary conditions like Birt-Hogg-Dubé. So there are these familial forms with people developing cancers commonly in these kindreds, and those are real. And lastly, if someone's on hemodialysis, they develop this cystic change in their kidney that puts them at risk for a cancer. These are the hereditary forms. In terms of how it presents, often it's unilateral, although some individuals will have multiple tumors or tumors in both kidneys. That's much rarer. And if you had multiple tumors in the kidney, it's often a type of tumor called a papillary tumor, and I'll get into that a little later. Unfortunately, some of our patients will present with what we call the too late triad, or we used to call it that. These are individuals who are unwell. They have blood in their urine, they have pain, and you can actually feel a bulge that represents the tumor. So that's an advanced case. What's more common though, nowadays is what we call incidental. Someone saw their family physician for vague abdominal discomfort or bloating. They get an ultrasound. Lo and behold, there's a growth in their kidney and the referral is made to a urologist. This is or a uro-oncologist. This is the most recent staging system. I don't want to get into big details, but anyone who looks into cancer, we often use these terms TNM. T is for the primary tumor. It usually describes the size of the tumor and its local extent. N describes lymph nodes because unfortunately cancer is often spread to lymph nodes. And M stands for metastasis. So if we actually see spots in organs outside of the original or primary site. This cartoon depicts that right here. When you see stage 1 is the most favorable, tends to be a small tumor just within the parenchyma or meat of the kidney. Stage 2 is usually, again, a size distinction. Once you get into stage 3, you start talking about other things like invasion to fat, or a thrombus, like a blood clot developing into the renal vein or higher. And unfortunately, stage 4 suggests invasion into local or adjacent organs, other structures that are close by. It truly is the tale of two tumors. We've, I think, mostly heard today about individuals with metastatic cancer or advanced disease. There's a number of people who have stage 1 tumors, really tiny, tiny tumors, a number of which have a very benevolent or indolent course. So there can be confusion for the public, because you might hear about one patient who has a kidney tumor and they said, my doctor said I don't have to do anything about this. And you might then hear another very dramatic story of an unfortunate individual with widespread disease. And you can see from these numbers, they're a little historic now, but if you're nodal positive or metastatic positive, you're looking at a much lower 5-year kind of progression-free survival than someone with a T1 or a T2 up there, which usually is cured. Histology, really just to be complete, clear cell is the most common. Histology refers to the pattern that the pathologist sees when he or she looks under the microscope at the tumor. And some of these different patterns can predict who's more likely to recur or not. But what I think many of you are starting to realize in ourselves is how do we get deeper into these histology patterns and the genetics so that we can develop better targeted therapies? Because although we call it kidney cancer, it's really a number of different kidney tumors of the kidney. Grading is the term that we use to represent how malignant or how cancerous it actually looks. How deranged have the cells become? So the pathologist looks at the kidney tumor, and the more abnormal the cells look, it's a higher score. It's called Fuhrman Grading, and it applies to clear cell. So a higher grade is much more significant. As you can see, grade 4 cancers are very serious, even in small tumors. Okay, imaging. Dr. Jewett alluded to this earlier, some of the testing when he talked about stage-specific testing. There are many tests, but I think the standard test would be a CT scan with dye. So if anyone is diagnosed with a kidney tumor, their doctor should, if it was an ultrasound initially, order a CAT scan with intravenous dye, because that'll show you the tumor and the blood vessels around the kidney. MRI's an excellent alternative. It has some other advantages. And an ultrasound is very reasonable, especially from the outset, or if you wanted to see if it was solid or cystic, meaning it had fluid in it. When we stage people, although we all want the best test, and everyone thinks an MR and a CAT scan is the best, actually sometimes we overdo it. And what I mean by that is a CT chest can be so good that it picks up tiny little spots that don't represent spread, but create confusion and anxiety. So we tend to recommend a chest x-ray, which is not as great in terms of its resolution, but we use that for the lower stage diseases, because we also have to manage the purse. And that's important, as you heard earlier, because we want to be able to use our funds in a universally funded system to direct it towards cancer therapies and other treatments that are currently not funded. Treatment. Surgery is the mainstay. We have some excellent new drugs, and the role of radiation is re-emerging, and we'll hear about that later. But if you go back years ago, and still to this day, surgery plays a big role in the management of kidney cancer. So T1A, those little guys, we often call them small renal masses or SERMs. And before the imaging era, more than 50% of kidney tumors were only found at autopsy. So now I'm speaking of remember the tale of two cities kind of? This is the good, the tale of two tumors. This is the good tumor, all right? Even though it's called a tumor, because we have to call it that, I'm going to speak to you now about the favorable little ones, where although they're called cancers, perhaps we're overdoing it as doctors. They do very well, these small tumors. They rarely spread. And importantly, The little ones are often benign, and the only way you can pick that up is with a biopsy. As you can see, although this is an older graph going up to 2001 only, the curves are rising and rising. Incidence means new diagnoses. So that's because more people are getting imaged. We're finding more and more of these little guys. And that leads to more and more surgery and more costs to the system. And no matter how great a surgeon you are, your patients do take some loss of quality of life with surgery. The incisions are painful. There's a risk with every admission to a hospital. And what I'm getting at is if you really don't need an operation, we shouldn't be performing it. Oh, I'll go through that fast so we don't look at that picture. Sorry about that. That one didn't get edited out. Biopsy. So I think Dr. Jewett stepped out, but a great deal of credit to Michael. He's a real pioneer and champion in this space, and this area of small renal masses has really been his contribution to the field. Biopsy is one of them, and pushing the envelope with biopsy. And that came back to us because we started to realize as we took out many more small tumors that in general, a number of them are benign, and of those that are malignant, a number of them are low grade. So what I'm saying is many of these small tumors perhaps aren't as bad as we thought they were. This is the biopsy image, and complications are low. It's very well tolerated. And I think this is something you're going to see more and more of. We've been doing a lot of research in this in our institution. We advocate for it. We think it's very important because although we want to operate on the right individuals, we feel equally strongly that if you don't need an operation, you shouldn't have it. So in general, we're successful 80% of the time, and it's a safe intervention. So I think you will see more and more biopsy of small kidney tumors, and you may hear of friends having this, and the role of biopsy is very important. Okay, so what do we do with these small tumors? We can either watch them, and that sounds crazy because your doctor told you you have a cancer, and I'll show you some slides to tell you why it may not be so crazy, and then we can operate. The term partial nephrectomy means to remove the tumor only and to save as much of the good kidney as you can. Energy ablation I'm not going to touch on, but that simply refers to having it burnt or frozen through a small needle that's inserted under guidance through your back. And then radical means removal of the entire kidney. Oops, sorry, can I go back one? Can you switch me back one? Yeah, okay, and then one forward now, great. Okay, so the natural history of small tumors. A number of people began to realize that patients do well with small tumors, and not because they wanted to observe them. They had some patients who were unfit for surgery, unwell, significant diabetes with strokes, history of heart attacks, and we knew the anesthetic risk was too high. So rather than just do nothing, we thought we would learn from these patients, and they were very compliant and cooperative, and we followed them with routine imaging to see how these tumors would grow. And what we found in general, as you can see over about 4 to 5 years here, that they grow very slowly. They grow about 2 to 3 millimeters a year on average. So then you do the math, and I say this respectfully. You have someone sitting across from you who's 85 years of age, who's had 2 heart attacks and a stroke, and they show up with a 1 centimeter renal tumor. It drives me crazy when I find out that someone offered them an operation, because this will grow at 2 millimeters a year. So we should be thoughtful in how we treat individuals, because it's not simply the tumor, it's the host. So we want to operate on healthy patients who we're going to make a difference in. And this is Michael's contribution again. So I'm going to go through this quickly, and now to this slide, which is going to speak to what I just told you earlier. There's a little statistics here. I apologize. It's called competing risks of death. And as we heard earlier, as Alex said, mortality is universal, no matter where you live. And it's an awkward and uncomfortable topic, but when you're an oncologist, you spend every day talking to patients about likelihood of death. And you just try to find the best way to do it. So competing causes of death is what we're looking at now, because my job as an oncologist is to keep you alive and well and not have you die due to your cancer. So they looked at roughly 7,000 people, and these curves are very nice curves. Blue is the likelihood of dying from something other than your kidney cancer. Red is the probability of a kidney cancer death. Across the top, oh, can you go back? I thought that was my pointer. We don't have a pointer. So across the top are tumors less than 4 centimeters, and you can see there that over time, the vast majority of people died from other causes. only a small number died from their kidney cancer. Okay? So, watching small kidney tumors is something that we will do in select patients. Those who we feel have a high risk of complications or perioperative death, and or have significant other illnesses. At Princess Margaret, I often see someone with another primary cancer who now has a small kidney tumor. And so they should be watched, but there's some caution. We're still learning here. We need to find better ways of predicting who has a small tumor that's going to become ugly and intervene early in those patients. Okay, surgery. So I had the privilege of working with these three giants, or two of these giants in the field. The gentleman to the top left is someone known as Charles Robson. He was actually the chief of urology at the Toronto Hospital, and he's the first individual to have described how to do a radical nephrectomy here. And the Robson staging system is named after him. He was Michael's boss, and then Michael was my boss. I worked at the Cleveland Clinic. Andy Novick, who is no longer with us, championed partial nephrectomy. And then the fellow with the mustache is Indy Gill, who is the pioneer of minimally invasive kidney surgery. So they have all had a great influence, and Michael has had a great influence on my career. Okay, not as graphical, it's a cartoon. Unfortunately, the way we do kidney surgery often is an incision above your 11th rib. And a number of people have that rib removed, so it hurts. No matter what, it's going to hurt. And we try our best to diminish pain, but there's pain involved. The kidney lives behind your ribs. It's hidden. It's not a low organ in your abdomen. It's high up under your lungs. This isn't a terrible flank incision, but it gives you an idea of what you can expect. It's actually one of the nicer looking ones. It's about 9 centimeters, but it can be larger, and 15% of people have their rib removed with surgery. Unfortunately, many people will have a bulge or chronic pain, even if everything is closed correctly. It's because the little nerves that run through there are going to get cut. For advanced cancer, sometimes we have no choice. We have to make a big cut because we have to perform surgery safely and take out a lot of disease. But whenever we can, we try to do things laparoscopically. Small little 5 millimeter, 10 millimeter incisions, and then take it out. Even though you still have to remove a large organ, take it out of a more strategic location, like an old appendectomy cut, low down, or a Fannin steel cut, we call it, just above the pubic bone, so that it's better tolerated by our patients. So that will give you a shorter hospital stay, less pain, cosmetically more favorable. All in all, return to work, everything else will come back more quickly if we do it minimally invasive. Partial nephrectomy, I'm going to speed up a bit because I want to stay on time. Again, as I told you, we do this whenever we can. We want to save kidneys, but in particular, if you have tumors in both kidneys or you already have some loss of kidney function, you really need a surgeon who respects kidney function. Okay, the easy answer is to say take out your entire kidney, to the point where I think it was a reflex. And we've gone through a process now of educating our colleagues. Kidney function is important. If you look at this study, which had over 1 million people, the worse your kidney function is, the higher your chance is of having a cardiovascular event, of being hospitalized, and of dying of all causes. We looked into kidney cancer surgical patients, same thing. More likely to have loss of kidney function if you took out the entire kidney. This nice study from Michigan, again, looked at partial nephrectomy versus radical nephrectomy. And as you can see at the bottom, if you treat 7 patients with a partial rather than a radical, you could avoid 1 death during an 8-year follow-up period. So we should really try to do partial nephrectomies when we can. But there's been a bit of a cognitive disconnect. Something went wrong in the story. We're big fans of this. The Europeans did a study where it's the gold standard of how we do research. We take 100 people or more and we put them in one group without us deciding whether they should be there or not. It's a coin toss. We take the other 100, we put them in the other group. It's called a randomized control trial. They go and receive the treatments in each arm. We try to remove all bias and then look at how well they did. Well, in this very well-designed study, there was no difference. Maybe we need longer follow-up. So this study kind of threw a little water on the flames and cooled off the partial nephrectomy train. But most of us who do this believe that there is still a big role for partial nephrectomy, and we should be doing it whenever it can be done safely. So we might see a little pullback in it. I'll move on quickly now. The importance of ischemia. The kidney suffers when we cut off the blood supply to it, so when we do partial nephrectomies, we should do them quickly or put ice on the kidney, if you hear your surgeons talking about that. And laparoscopic partial nephrectomy. So nowadays, we try to do them as often as we can laparoscopically, 3-4 small holes, and especially the partial nephrectomy, because we're often taking out small tumors that are 3-4 centimeters. They'll come out of an incision this big. We put them in a little Ziploc bag and take them out. And that's what it looks like on the cartoon. Those are the cuts you have. The black circles represent where the incisions occur. And these are some of my old slides I should have did. And then robotic, the last frontier. Very expensive, but now we're doing our minimally invasive surgery, robot-assisted. And for sake of time, I'll close out here. So I think you're going to see more and more kidney tumor biopsy for small masses. Don't be offended if you or someone you know who has a very small tumor is offered this watchful waiting. It's not being disrespectful. We're actually trying to protect that person. In Ontario, if you are aged 80 or older and you have a kidney operation, you have about a 10% chance of dying within 30 days. And that's because of the stress of an operation in someone who's older and unwell. Sometimes we have no choice, but there's a high 30-day mortality just based on the host. So don't be offended if we say, let's watch this one. Although the trial did not show a benefit for kidney-sparing strategies, I believe that the momentum is still in this direction. Open surgery is necessary in some advanced cases. We cannot do laparoscopy for all of them, but when it is indicated, there's clear advantages in terms of your recovery. And lastly, as I always say to my residents and fellows, the decision is more important than the incision. Okay, just because you can do it sometimes, maybe it's still better to do it the conventional way with a cut, depending on the disease. Thank you.